All right, let's jump straight into the clinical shift today. No fluff, no basic definitions. We're aggressively targeting the high-yield decision-making logic you absolutely need for tackling complex board exam presentations. So today's explainer is all about rapid triage algorithms for anesthesia complications and pediatric CNS emergencies.
Okay, let's dive right into this. Here's your clinical branching logic board. Imagine you're on the ward and you need to rapidly process these if-then scenarios. We'll be navigating neurologic symptoms post-anesthesia, systemic hyperthermic cascades in the OR, visual diagnostic patterns for infant head shapes, and critical neonatal bleeding risks. Your job? Recognize the pattern and know the exact immediate next step.
So our first major triage branch, complications following a labor epidural. And remember, those are typically placed at T10 to L1 for first-stage labor or S2 to S4 for the second stage. Now, if a patient complains of a headache or back pain right after the procedure, you have to immediately distinguish between a benign complication and a surgical emergency. A post-dural puncture headache is positional. It's significantly worse when they sit upright and gets better when they lie supine, all because of a persistent CSF leak. It's usually self-limiting, or you treat it with an epidural blood patch. But contrast this with a spinal epidural hematoma. This is characterized by progressive, localized back pain accompanied by expanding motor or sensory deficits or maybe new bowel and bladder dysfunction. Guys, this is a red alert emergency.
When you suspect a spinal epidural hematoma, time is spine. This complication is incredibly high risk, especially in older adults who might be on antithrombotic medications. The pathway here is rigid. Step 1, you recognize that localized back pain paired with progressive deficits. Step 2, you do not wait. You order an urgent MRI immediately. And Step 3, the patient is prepped for emergency neurosurgical decompression to save their spinal cord function.
And this brilliantly illustrates our ultimate mimic, the spinal epidural abscess. Take a look at the hyper-intense epidural collection clearly compressing the spinal cord there. It presents with the exact same progressive neurological deficits as a hematoma, but your major clinical clue is the classic triad. You gotta look for fever, localized severe back pain, and neurologic findings. If you spot this triad, especially in an IV drug user or an immunosuppressed patient, you need to think abscess. Draw blood cultures, start broad-spectrum antibiotics, and prep for urgent decompression.
All right, let's shift to systemic emergencies. You have a patient with extreme rigidity and hyperthermia. Is it malignant hyperthermia or neuroleptic malignant syndrome? To definitively separate these on test day, look closely at the time course and the pharmacological trigger. Malignant hyperthermia unfolds over minutes in the OR and is triggered by volatile anesthetics or succinylcholine. Neuroleptic malignant syndrome, on the flip side, develops over days and is triggered by dopamine-blocking antipsychotic drugs.
The exact pathophysiological sequence for malignant hyperthermia is completely rigid. A genetically susceptible patient gets a volatile anesthetic or succinylcholine. Intracellular calcium just floods the muscle cells. Now pay close attention right here, because hypercarbia, a rising CO2 level that is completely resistant to increased minute ventilation, is your absolute earliest, most reliable clue. Then comes the masseter rigidity, the sinus tachycardia, rhabdomyolysis, and only late in the game do you see the hyperthermia. You treat this by immediately stopping the anesthetic, providing supportive cooling, and hitting them with dantrolene.
So, the crucial point is understanding the specific dangers of succinylcholine way beyond just malignant hyperthermia. Succinylcholine acts by depolarizing the neuromuscular junction, which inherently causes an efflux of potassium ions. In a normal patient, sure, this is mild. But in patients with severe burns, massive crush trauma, stroke, or denervation injuries, those receptors are upregulated. Giving succinylcholine in those scenarios causes massive, sudden hyperkalemia, and that will rapidly lead to a lethal cardiac arrhythmia.
Our final anesthesia pitfall is local anesthetic systemic toxicity, or LAST. This happens when a local anesthetic, which was meant for a nerve block or an epidural testos, is inadvertently injected right into a blood vessel. The patient is going to suddenly complain of perioral numbness, a metallic taste in their mouth, or maybe tinnitus. This is followed incredibly rapidly by tachycardia, hypertension, and potentially even generalized seizures. Immediate drug cessation and aggressive supportive care are absolutely required here.
Moving on to Triage Branch 3. Pediatric CNS visual diagnoses. Now, what's really interesting about this slide is how visually defining the difference between a benign condition and a surgical one is just so crucial. On the right, we have positional plagiocephaly. Notice how the sutures remain open. The skull is just mechanically flattened, often at the occiput, simply from the baby lying in one position. But take a look at the left.
Craniosynostosis. Here you actually see the premature fusion of specific suture lines, like the coronal suture, and that forces the skull to grow asymmetrically in other directions just to accommodate the growing brain. Positional flattening is managed conservatively, but a fused suture, that requires surgical intervention. Let's move into the NICU. Here we're looking at a neonatal intraventricular hemorrhage. You can clearly see the hyperechoic blood filling the ventricles and causing pretty prominent ventricular megaly. The critical takeaway here for your exams is that up to half of these devastating hemorrhages are completely clinically silent at first, and because of this, routine cranial ultrasound screening is absolutely mandatory for premature infants born before 30 to 32 weeks gestation. The clinical consequences of an expanding interventricular hemorrhage are really severe. Most notably, the high risk of developing communicating hydrocephalus as all those blood products clog up the arachnoid granulations. Because our treatment options are so limited once the bleeding actually starts, prevention is literally everything. The single most vital preventative step we have is administering antenatal maternal corticosteroids to mothers in preterm labor, which really helps mature those fragile fetal germinal matrix blood vessels.
Now, in evaluating a child presenting with acute hemiplegia, so sudden, one-sided weakness, you have to differentiate a hemiplegic migraine from a true pediatric stroke. A hemiplegic migraine often presents with a preceding visual aura, a strong family history, and uniquely, it actually self-resolves. However, if the child has a history of sickle cell disease, congenital heart disease, or recent trauma, you have to suspect a stroke and order an urgent MRI and MRA. And remember this rule. Never assume it's just a Todd's paralysis post-seizure until a true stroke is definitively excluded.
All right, shifting gears to Triage Branch 4, Critical Adult Neuroemergencies. Imagine a patient presents with a classic thunderclap headache, one that reaches agonizing intensity in under an hour. Notice the hyperintense, bright white blood pooling right there in the basal cisterns and subarachnoid space. This is a subarachnoid hemorrhage, most commonly stemming from a ruptured aneurysm. Immediate management here has to include strict blood pressure control to prevent rebleeding and nimodipine to prevent ischemic vasospasm.
Let's move to the next slide and see how this builds. Mapping out the exact anatomical shifts to the resulting localized deficits for brain herniation syndromes is vital. In a subfalconine herniation, the cingulate gyrus shifts, compressing the anterior cerebral artery, which causes contralateral leg weakness. In an uncal herniation, the medial temporal lobe pushes down, compressing cranial nerve 3, and that results in an ipsilateral fixed, dilated pupil. Central herniation, meanwhile, causes bilateral mid-position fixed pupils and decortic posturing. And finally, a tonsillar herniation pushes right through the foramen magnum, immediately causing coma, flaccid paralysis, and respiratory arrest.
Okay, let's wrap this up with the rapid-fire algorithm summary. We're initiating our final rapid-fire recall sequence to cement these pathways into your working memory before testing.
First, retapping neuroaxial complications. If the headache is positional, improving when supine, it's a post-dural puncture CSF leak. If the back pain is paired with rapidly progressive neurologic deficits, it's an epidural hematoma, requiring an urgent MRI. But if you see progressive deficits alongside that classic triad of fever and localized pain, you're looking at an epidural abscess.
Next up, systemic toxicities. Hyperthermia unfolding in minutes after succinylcholine with rising CO2, that's malignant hyperthermia. Hyperthermia developing over days after giving haloperidol, neuroleptic malignant syndrome. What about perioral numbness and seizures immediately following a local anesthetic block? That is local anesthetic systemic toxicity from an intravascular injection.
Finally, pediatric CNS visual diagnosis. A flattened head with open sutures is positional plagiocephaly. An asymmetric head with premature fusion lines is craniosynostosis, which needs surgery. And do not forget the strict screening rule. All premature infants born before 32 weeks get a routine cranial ultrasound to check for silent intraventricular hemorrhages.
I'll leave you with this final, multi-step integration question to ponder. You're managing a patient recovering from severe burns. During a subsequent intubation, they develop a sudden, lethal cardiac arrhythmia. So what specific receptor did your medication just activate? And exactly what ion rushed out of the cell to cause the arrest? Think about the succinylcholine hyperkalemia pathway. Lock that logic in, and you'll be more than ready. See you on the next explainer.